Very, very cordial congratulations to you to DOAMS sessions. And you already know before we informed you that the history taking approach and the practice will be here, especially designed for uh, beginners. So we congratulated you all who first passed your part 2 written exam in the last month, result published, and again it is our opportunity to again to tell you congratulations and come to the PACES world, the last step of your exam. So what we will highlight, you already know that how to talk to the patient is very important skill. It's not only for the history, it is important in other stations as well. I will touch something, though we may not complete all the aspects of how to talk because the remaining stations will be later. Jargon and the layman's terms I will tell in course of the practice time. And what is the Royal College of Physicians checklist, especially checklist for the history taking. And we will show you how DOAMS presented a unique history format and how it will be useful, how to utilize it. And in the last one is that your question you can ask me actively. Don't feel shy. If you have any question regarding your exam future planning, you will be given the time to discuss with me. Anytime you can raise your hand also. And for purpose of good conduct of the session, what we have to do is that you will be unmuted from here, and only after getting the permission you can unmute yourself. We will mute now, already muted you all. Whenever you have your question, you raise your hand. I think as you are user of Zoom, this device for a long time, just to minimize the noise and others. I hope that every person, every colleague will be cordial and serious, sincere up to the end, and we will try our best to give you some lights that you can prepare yourself, especially in the history taking. So with the introduction, myself, I am Dr. Usman Ghani, as your chief instructor or mentor from our institute, this one. We like to come to the talk in the real talk now. This is holistic approach to the patient. The concept of a physician, how we deal a patient with. It should be a holistic approach. So holistic approach means not only we will be diagnosing the problem of the patient, diagnosing a disease, but we will address a patient as a whole, as a person. For that, we have to take many informations. The main weapon of the information is the history taking. Though we are using three weapons together. You see how the general observation plus history taking. And traditionally in our learning, the general observation remained a little hidden topic, but we are practicing. General observation is going side by side during history taking. For that, it's my personal interest to add the word general observation in the history taking part. Then we will go for the physical examination and then investigations. So the three main box of data, rather to say, and the three weapons we are using as a clinical weapon to gather the informations. So consultation means just getting information and giving advice. So history is the main and best weapon, rather to say. I will try my best to prove it in today's discussion. So in the history taking or examination or investigation, what are our aims? All, not only diagnosis. So around 7 I accumulated by myself. If you want to add, you can add many more also. The number one is the diagnosis, no doubt, to exclude differential diagnosis, and the etiology of the diagnosis, then the complication of the disease, any other comorbidities, and number 5 is very, very important. How much suffering patients having now? That means what are the functional status of the organ diseased, suppose heart disease, kidney disease. And finally, the proper management plan. And lastly, for research purpose also, we have to take history, examination, and investigations. So these are very basic ideation. During calculation of the history taking or after investigation, how to reach a diagnosis. So this is a proposed plan from DOAMS actually, that was my personal thinking. How to reach a diagnosis, how to strengthen the importance of the data from the history, from the examination or from the investigation. One a clinical feature I post here, suppose if we can think that this is breathlessness. So breathlessness may come from respiratory system, may come from the disease of the cardiovascular disease, especially heart, may come from renal or urinary problem as well. So these are two or three main systems. Even then, from any disease can cause breathlessness in many direct or indirect ways. So breathlessness, how indicate us that coming from the respirology, if patient having cough. So simply we can tell that this breathlessness may be due to respiratory illness. And second, cardiovascular, patient might have central chest pain, maybe ischemic heart disease causing heart failure. Nothing is there, could be renal, metabolic one, metabolic acidosis. So in that way, we make a simple calculative manner to strengthen our diagnostic efficiency. No system is found or all systems are involved together. It seems to be a functional disease. So I like to add a little more also. It is only we are analyzing the symptoms. Suppose in the thyroid disease, you know that if you diagnose hypothyroidism, okay, clinical feature may be there or not. Usually we have to go for the two investigations, TSH and free T4. Come to the common endocrine disease, diabetes. Almost diabetes is asymptomatic disease, especially in the type 2 diabetes. How we are diagnosing? We are advising fasting blood sugar 2 hour postprandial of 75 gram glucose drink or hemoglobin A1C. The diagnostic rule is that from these three investigations, two investigations should be positive. This is rule of two. Again, how rule of two come in the field? Suppose your one investigation is positive, in a diagnostic level is there, but no other one positive, but patient having typical symptoms of diabetes. That is polyuria, polydipsia, and weight change. If you can go through your medicine book, you can see there, the box is given there, the diagnostic criteria of a diabetes. For each and everywhere, these rules are actually prevailing. What I observe that, and I like to share my opinion with you. If you think yourself, it will be very easy for you for diagnostic pathway development. That I will go in that way, because you have to again identify the etiology of the disease. You have to plan investigation. So how the history helping us? First work of the history is a bulk big area in the patient evaluation. So history guides ours for the examination plan. That means the clinical examination. History and examination guide for investigation plan. History, examination, and investigation all together guide us for a proper management plan. So what I was thinking again, that it could be a funnel shape approach. The big one is the history. We have to talk much more to the patient. Then we made an intermediate pathway, the physical examination of the relevant system. In real practice also, we are practicing not each system. We have to identify which system we will examine for. So history helping us. And then finally, in the little area, that we are going through an investigation pathway to confirm the diagnosis. This is, I like to repeat, investigation is to confirm the diagnosis. So without history and examination, most of the disease not to be diagnosed properly is not possible. So history, examination, and investigation, the philosophy of both of three information source, we can think in a funnel approach. Initially bigger and coming to the narrow, and finally the one diagnosis will come out. Now come to your examination, the structure. This is the PACES, and those who attended our last session in the previous few weeks, maybe that the PACES preparation tips. I tried my best to give you some idea there. Even then, those who are new maybe today, so it will be better for you also. Just to tell you that there are 5 stations. The station is the station 2, the prevailing is now the system carousel. And station 5, you just have a look here. So some history skill will be needed in the station 5. It is very, very critical station to pass the PACES. But interesting is that after 1 year or 2 year, the system will be changed, but content will be same. So I just have chance to tell you some comparative information to give you. First, you look at this is station 2 and the station 5. There are two station 5, 1 and 2 of 10 minute, 10 minute. This is all together 20 minutes. So today we will discuss much more about this station. Another day we will discuss, but in the coming slide, just to inform you, and it may be practical or realistic for you, those who passed just recently. If you cannot pass, unfortunately, I will like to say that within this year, suppose coming 2021, it is planned already now that from 2022, there will be the carousel as such. It was supposed to be started from this 2020. That means they already running the finishing year for this corona problem. You understand that it could not be started. So the Royal College now planned to start from 2022. So what is the change here? I think this is also relevant for you, that you may not appear even in the within 1 year also, some of you in real life situation. So history, actually no station will be there. It is true. Suppose station 2, now they have given clinical consultation 20 minutes. So this is a modification. The station 5 remain as clinical consultation, but it is again 20 minutes, not that 10 minutes, 10 minutes. This is a modification. So history actually will be here in the station 2 and station 5. It will be a big clinical consultation station. It will be big clinical consultation station of 15 minutes. There will be no gap, and 5-minute examiner will cross you. That means they will ask you, discuss with you. So rather now history becoming getting more importance than the old one. That means the current one ongoing, that you have to be skilled or very efficient to take the history, and you have to do this history taking in the station 2 and station 5. And communication station again divided into 2, just to add you, to remind you, to make a complete discussion of this coming carousel. The station communication 20 minutes divided into 10 minute, 10 minute station. This is only just added information for you. So up to this is the PACES structure. Now I come to inform you that how the PACES instruction given into the examiner examination hall, and how the candidate comes and how examiner wishes. I have shown in the video, the Royal College video before. Sorry, please take care of your annotation. Okay. So it is the history taking paper, though it is the font size is not maybe visible to you. I will make a little modification to show you. So all the informations are actually not variable here. Some information is very common. So from very before we are oriented with these informations, we may not give attention to there. There are main 3 areas of this sheet. I'm just showing to you. There are 3 areas. This is the first paragraph about the patient details. Patient Mrs. Bretty Drake, a 56-year-old woman, is very important as identification, the age and gender. And sometimes given he is a housewife or something, may be given or may not be given. Your role, very, very important what you are. You are not consultant there. You are SHO, senior house officer, or you may be designated in this manner also, that you are the doctor in general medical outpatient clinic. Remember, you are not working in the ward inside. You are not working in other department. Patient may have the symptom of cardiology, but you are working in the general medical department. So what approach you have to attain, this is also important according to your identity. So be careful about your role. And the complaint is there: weight loss, diabetes mellitus, and abnormal liver function. So this is the presenting complaint. So traditionally, what we know about the complaint, that patient telling chest pain, abdominal pain, this is the complaint. No, patient may present with the investigation report. So this is also complaint. This is also complaint. But in Royal College exam situation or the Western structured clinical practice may not be available in the South Asian many countries like us. It is letter of general physician or general practitioner, GP. GP is writing a letter to you, that patient brief as such, and he is expecting something from you, suggestion, treatment plan, and other. So what will be your role? It is given by the examiner or by the Royal College in the exam. You can look at the bottom panel. For any history, this is almost common. Your task is to interview patient based on the history you obtain, construct a differential diagnosis, and plan for investigation. So this is the thing what a doctor does in his life, her life, that take information, give management. So taking information, there are three ways: history taking, examination, investigation. Here, in this session, your history taking skill is discussed or evaluated, analysis is done. But you have to have in your mind what will be your examination plan also, what will be your investigation plan, what will be your management plan. And the last word, last sentence, you should explain these to patient and answer any questions they may have. It is mandatory. If patient asks you a question, you are bound to answer. Again, examiner will ask you the question, you will answer to the examiner. But the philosophy is that examiner will not ask very new thing. What is gone between you and the patient, they will try to clarify this. That why doctor you are asking this thing, why, what is your plan, and why you are planning this, can you tell me the reason? This will be the discussion. So all examination station, you can think that relatively it is a passive examination station. Why I use the word passive? Because many of the countries we are facing the examination, the traditional one, like the South Asian countries and others, examiners are in front of us, they are asking the question, we are giving the answer. But in this exam, PACES, many of you know that patient will talk to you, patient will ask you. Examiner also asks, but this role, they are passive. What you answer to the patient, they will ask you that why you have given this answer, what is the reason, maybe in that manner. So you will come to know day by day in future. So I advise you, please have a look and try to identify something from here. This is the information given by the general practitioner. May I request you to use your pen and pencil, because we will come later to a practice session. Those who will be interested, I will give the chance to them to talk with me. I will try my best to be a good surrogate today. So these are the informations. What are the informations you are getting now? You know the history proforma is own history proforma with you. From there, you can write some shorthands. There is some history, there are some investigations, informations, and your task already given. But in very simple information, I like to tell you that patient having the weight loss. Recently, patient developed diabetes for 2 weeks, and weight loss of the patient of the last 2 weeks. BMI is big, high, 28, and patient has done some. He's also patient of asthma. Uh, Patient is on inhalers, as well as patient taking some bendroflumethiazide also for patient having hypertension. Otherwise, why is he taking bendroflumethiazide? So these are the drug history, you know. These are some patient informations, and these are the drug history means the bendroflumethiazide until the salbutamol. These are the informations of the investigations done. So this informations of the investigation also a part of history taking. Remember it. But the problematic investigation results are here. Alkaline phosphatase is high. Alanine aminotransferase is almost normal. Total bilirubin is high, and serum albumin just below normal. Gamma GT is high. From this investigation, the intelligent doctor, my beloved colleague, you can understand what is going on, what is happening inside the patient. We will come to that discussion. And I am just showing the how Royal College designed this information for the candidate. In addition, patient plasma glucose fasting is 12 to 13 around these 2 weeks time. Someday 11, someday 12, like that. And why the patient having such problem, especially the liver problem, GP is in confusion. So GP tries to know or expect to know from you that you will explain this to your GP. So meaning is that in the examination, don't forget that expectation of general practitioners. Though it will not come in the field in the discussion, but you have to give a reply to the GP that I have done this thing later. But in the very first day, it will not be a part of the discussion, because you take the history, make an investigation plan, then you will get the summary, and then you have to write to the GP. So examiner intelligently may ask you that After finishing everything, what could be your responsibility? So you have to think that actually examiner tries to ask you that you will do something for the patient and everything okay, but side by side you will give a reference, or rather to say information later to the GP that your patient is such and such. So consultation then could be completed up for one patient. So this is some technical thing. Then now I am jumping to the next slide. What actually examiner will ask to you? This is a prototype one almost, and we all the doctors should be ready to answer such question from each station, especially in the history. They will ask about the diagnosis, what are the differential diagnosis, and which problem is currently active, because diagnosis may be two or three together. You see, you can see that patient having now the diabetes already diagnosed by the GP, patient having liver problem, patient having weight loss, a symptom, not a diagnosis one. But which one is very important currently active? You can find that the liver problem is currently active here. But is there any other active problem? Clinically, we can identify it. And why you are telling that this is very, very active? So reason is there that the alkaline phosphatase is high, and that is very recently happened phenomena. That may be explanation in your mind. And further examination or further history even or investigation, what you will go for. So signs and complication you should look for on examination. That means you took the history, now next uh, complications identification or the signs you will look for. This may be your planning, and then investigation plan, and you how you manage this case. So in very simply, if you like to summarize the examiner asking the information, actually you have to be ready with is number one, what is your diagnosis, what is your differential diagnosis, how will you examine or investigate the case further, how will you manage this case. So these three, four broad headings, we must be ready with us, and we have to answer to the examiner's question. Thing will be that, again, I'm showing a bigger slide, that you will think that it could be some abnormal liver function. So you will tell that there may be some obstructive jaundice in this case. And if it is obstructive jaundice, which is causing the obstruction? This is very, very major question there. What other complications are there? What type of diabetes it is, and how to manage the patient of the diabetes right now, blood sugar, and the is there any dangerous disease or not? This is called red flag in the history taking. So I think I will tell you in course of practice also, because if I tell theoretical everything very beginning, may be difficult to you for understanding. So if I come to the practice session now, regarding this history taking one, so let us say that introduction, how a person introduce as a doctor, we have to introduce a patient as a human. So I'm very delighted to show you that this honorable ex-president of United States of America, you know that the last few days there was very important election there. So how he actually introduced a voter, that means one citizen of America, how to invite her. So I think there is some learning. For that, I just draw your attention for 1 minute, maybe 2 minutes here. After that, we will go for the practice. I am requesting all of you to get ready to raise your hand if you want to talk to me, how to address a patient in the history station or communication or examination, whatever it is. So let us hear from Honorable President Barack Obama. I hope that you will not lose your patience. Okay. So you see, I think you can hear. Dr. Sharar, can you help?
Hey, Alyssa, this is Barack Obama. I used to be the president, remember? So I am doing phone banking for Joe Biden, and you're one of the people I'm calling. How are you doing? Don't, uh-oh. All I want to do is to remind you that Election Day is Tuesday, and this is going to be a really close election, and I'd love for you to vote for Joe Biden and Kamala, and if If you don't know your polling location, I can give it to you, give you any information that you need. Well, that's great. And make sure, are you reaching out to family and friends and all that? Okay, you tell them Barack specifically asked them to please vote. Who's that in the background there? 8 months old, so you've got a new guy in the house. Well, he sounds like he is either hungry, needs his diaper changed, or just doesn't like mom giving attention to somebody else.
Can I go into phone call?
Well, that may be it. You know, if you want to put him on the phone, I'm happy to talk to him. Hey, Jax, what's going on, man? Do what your mom says. I would chat for you for quite some time, but when you have 8 months old, you can't be on the phone too long. Bye-bye.
So I like to thank you all also, my beloved participant today, to hear this, what I say, the introduction of President Barack Obama to a voter of US in the last election. But I think that in this talk, in the live, you understand that how a person approach a person, other person, that first you have to tell your identity, that what I am, you already observed here. And you are telling that what your agenda to talk about. He started it, I am here, Barack Obama, to talk about or invite you for voting in favor of Mr. John Biden and Kamala, like that. So doctor is to tell my agenda in this station, I am here, such and such, I have to do. I will show you the structure in our format. And other observation also there, that if you need any information, please let me know. I will give you how to vote, and then others. You already observed. Lastly, President Barack Obama intelligently interacted with the baby of 8 months. He understand that actually 8-month baby cannot communicate well, but this is the courtesy. The president's interest was to convince the mother to vote in favor of his candidate, in favor of Mr. Joe Biden. But thing is that in the patient also, in the consultation also, you may find that attendant is there, or father, mother is there, or in the examination hall, you can find a translator is there. So we should not ignore them. Whatever there, we like to address, and we like to smile even minimum or 1 or 2 seconds. So this is the way of introduction. Now coming to our PACES exam introduction, how can we start with? So now I am requesting anyone to raise your hand who will be actually willing to talk to me only this introduction part, how to start with a patient. Can you raise your hand, please? Then I will give you mic. Anyone, please, feel free. It is your chance. Dr. Adnan, ready? Oh, fine. Okay, everybody get ready. I will actually sectorize. I made different parts of this history. And if you have patient, I can continue a few more time also. If anybody willing, you can raise your hand in different coming part of the history section. So welcome, Dr. Adnan. Can you hear me?
Yes, sir. Thank you.
Very good, Adnan. So I think you understand what I mean, what you are to do now. You patient having the problem, what the problem patient with?
Weight loss, diabetes.
And abnormal liver function test.
Abnormal liver function test.
So if you go through this thing, hello, Mr. That's he was not Mr. He was actually Mrs. Can you remember the patient name? Can you remember the patient?
I just forgot it.
That is the thing, my beloved other colleagues. Remember, Dr. Adnan forgotten. And this may happen in an exam. You have written all the information from A to Z. Lastly, when entering, you forgot the name of the patient. So it's not good. Try to remember the name of the patient. Okay, Dr. Adnan, can I tell you the name of the patient?
Yes, sir. Yes, sir. Too.
I think anybody can help you, other colleagues, those who are hearing, if they want. Okay. Anyway, it will take time. So Mrs. Drake. Mrs. Drake. You know the last word, you know how to address that, the last word to be addressed. Mrs. Drake.
Yes.
So Mrs. Drake, an elderly lady, 50 some plus ages. So you have to address Mrs. Drake. Good morning or good evening, whatever you say.
I'm just going. I'm just going with it, sir.
Yes. Finally, I came to know that you are suffering from sugar problem,
Okay.
other thing. I like to hear from you that how you actually talk about this thing. Up to this, how can I help you? So for everybody, may I request other all the participants, let's hear us how Dr. Adnan is starting with me. That if you have any
Okay.
questions, you can raise your hand also regarding this introductory part. It's very, very important. You know that if your introduction part is very nice, gentle, polite, patient will be very convinced to talk to you further. So it's a very important part, opening the door. Welcome, Dr. Adnan. Please start.
Hello, Mrs. Drake. Good morning.
Hello, doctor.
I am Dr. Adnan on duty today. I am here to talk to you. Are you comfortable?
Yeah, doctor. Okay, thank you.
Do you like to invite anyone else in our discussion?
No need, doctor. I think I'm enough to talk to you.
Would you mind if I take some note? It will be confidential.
Oh, no problem. That's fine. Yes, good, doctor. It should be confidential. Thank you, doctor.
I came to know from your GP later that you are suffering from some sugar problem, weight loss, and some abnormal liver function test.
Yes, doctor, you are right. I have sugar problem for the last around 2 weeks, and I have some liver problem. I came to know from GP as GP has done some blood test from there.
So how
And
can I?
doctor, I am losing my weight also, doctor. Yes, it's very significantly. I'm thinking what is happening to me, doctor.
So how can I help you?
Okay, doctor. Dr. Agdan, thank you very much. This is the episode only up to there. So, my beloved colleagues, you have heard these. If you have any query, please, can you discuss? Can you raise your hand and discuss with me that if you have any better pro forma, you can discuss with us. You can contribute also. Can you raise your hand? Dr. Sharar, I was asking Dr. Sharar also because I know him. Dr. Sharar, can you raise your hand so that I can identify? Then I can give you the chance to talk. Dr. Sharar, can you raise your hand? Yes, Sharar, welcome. So, Dr. Sharar, can you try what Dr. Adnan has done?
Yes, sir. I can
Please,
try the
please,
same
please,
thing.
please. Try your best.
I had one thing to add to
Please.
this this session as well.
Yeah.
You said that I'm going to introduce myself. So, is there any part of the exam where I need to identify the patient as well? Should I ask the patient that are you Mrs. Drake in this case, or should I
Yeah.
just go ahead and say hello, Mrs. Drake?
Oh, yes. Fantastic question from you. Usually, I like to answer this question in a manner that some tradition. I told you that everybody that there may be different structure of introduction. So, suppose am I talking to Mrs. Drake? This is one way of asking. But if I say, "Hello, Mrs. Drake. Good morning," what does it mean?
Yeah.
I am I am actually addressing Mrs. Drake here. So identification is finished there. So you are saving
Okay.
your time. You're saving your some seconds here. And patient will feel better that before coming to the station, you already know the patient's name. It will give a very good feeling to the patient. But what the structure you're told, I actually don't like to ignore it as well. Maybe some of you also oriented in that manner. But my sense in a logic that if you address by the name, usually in the examination, there will be no different patient. This is true. But in the real life, maybe that if in the consultation room or the waiting room, somewhere else, the patient attendant is sitting. For that, we have to identify first. And identification will be very important in other part of the carousel, especially in the communication where you will be giving breaking bad news or some other thing. There will be some extra importance
Okay.
given in the identification. But here, simply, Dr. Sharar, that hello, Mrs. Drake, good evening. I think, in my sense, it would be better. If you think it is better, you can practice. Or other structure you told me, it will also not a bad one. Okay, Dr. Sharar. Any other thing in your mind?
Okay, well, okay, that's one way. The thing, what happens in my case, I also did some practice
Yeah.
in the last few days. So the same thing that happened to Dr. Adnan here
Yeah.
is that it is very common that we forget the name of the patient.
Yeah, Dr.
So
Sharar. I know it.
that in an exam situation can really
Oh,
cause a lot of trouble.
how to overcome this forgetfulness? May I tell you?
Yeah.
I think other colleagues don't like to hear. They are
Yes,
not
sure.
raising the hand. They are only listening to me. Can I see some hands that you have raised? You like to know that how to overcome that you suddenly forgotten the name of the patient, or who can say also answer? You can share also. Feel free, please, my beloved colleagues there. I think they are not willing to raise the hand, or they don't know. Anyway, let's hear. No problem. So if you forget the name of some person, they are also a courtesy, right? That I forgot the name. This is my mistake. I was to
Okay.
know the name of the patient because the name is given outside in the door. So very sorrily, actually, we have to tell. How we can tell is that uh, first, any person, maybe patient or not, we have to tell good morning. There is no mistake. May I know your good name, please? Okay, you can start in that manner. You can start that first. You introduce yourself. I am Dr. Such and Such working here. May I know your good name, please? So it is a better way in my sense. May I know your good name, please? And some cultures, in some country, people, they are not oriented in that gentle, polite approach. Dr. Shara, you know that. What is your name? Is not it, Dr. Shara, to ask? What is your name? You have seen many where. It is
Yeah,
not a
exactly.
professional approach. It's not a professional approach. It is a very layman general approach. We have to be professional. I will show you the professional approach. How could it be? But I don't know how much time I will get with you tonight. If you are with me, if you like to continue, I can talk more time also. Okay, Sharar, can you start, please? Just to finish this thing.
Okay, I'll start. Hello, Mrs. Drake. Good morning. I am Dr. Shara Islam, and I am here to talk to you. So, is
Okay,
it
doctor.
okay that I can talk to you?
Okay, doctor. Okay.
So, are you comfortable here?
Yeah, yeah, doctor. It's very good. There is no noise, and that's fine. Fine, doctor. Thank you.
Okay. Would you like someone else to be in this discussion with us?
Do you think that, doctor, you need someone to be with me?
No, if you can provide the informations, I am okay with it.
No, no, doctor. I think
If you
I
would
am
like
enough.
to invite anyone else,
Okay, doctor.
okay.
Thank you very much. If I feel, then I will call my brother outside there anytime. Thank you, doctor.
Okay, thank you. Would you mind if I take some notes here? It will remain confidential.
No, 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 doctor. No problem. Thank you very much. Here, Dr. Sharar, I like to pause there. I didn't pause, Dr. Adnan, before. Would you mind if I take
Okay.
some notes? Give few seconds to answer. Is a make a
Oh,
dialogue
okay.
drama that. No, doctor, no problem. Then, if you tell later, it will be confidential. Your patient will be more and more happy. Oh, doctor, fantastic!
Okay,
Thank you
okay,
very much. So this is a classic one, just to show some acting or like that. Can you start from there, doctor? Would you mind?
okay. Would you mind if I take some notes?
No problem, doctor. It will
Okay.
be.
I can
It will.
assure you that it will be confidential.
Thank you, doctor. Fantastic. Thank you very much. Expression maybe like that.
Okay.
Okay. To carry on. Next one. I.
I learned from your GP that you are suffering from some sugar problems as well as weight loss, and you also had some abnormal liver function tests as well.
Yeah, yeah, doctor. You are right. You are right.
Okay. How can I help you now?
Okay, Dr. Sharat, thank you very much. You have done nicely. Uh, Again, just to finish here, I will jump to the next slide. I came to know that you are suffering from, again, it is a matter of what I say, the forgetfulness, rather to say, that you might forget the name of the patient, you might forget the presenting complaints of the patient. But as you are given a big paper, you will be writing there. You can carry the paper with you up to the patient inside the room also. From the paper also you can see, but just you don't know the problem of the patient. You are looking to the paper and telling to the patient how could this scenario be alike, not good one. So it should be memorized before entering to the chamber or the room exam hall. But unfortunately, if you forgot the patient's problem, better not to look at the paper. Okay, if you look, also try to be very careful that you are not losing eye to eye contact to the patient. So keep the paper in between in a manner that you are looking to the paper and telling to the patient. Otherwise you can tell that without telling this thing, how can I help you? That's enough. Without telling the problem, let the patient tell his or her story. There will be no problem. So this is very, very introductory part, Dr. Sharar. Thank you very much. Okay, I am now coming to the next part of the presenting problem of the patient. So again, I will invite you, but to take the history, this is actually the format designed by DOAMS, how to proceed on the history. I am just trying to explain from one by one a little. The number point one, we have already finished, greet and meet, introduction, identification. Now the presenting complaint already told by the doctor to the patient. Now the elaboration of the problems and the further discussion. In any symptom, we propose a mnemonic. Many of you know that the very, very renowned mnemonic for the pain is the Socrates. And some other symptom also, there may be other mnemonic, but in my sense that many mnemonics may be a burden for you. For that, we try to develop a uniform mnemonic for each and every symptom almost. So this is the OPD CATS. We have seen that the onset, progression, place mean the location of the symptom, duration, character, aggravating, relieving factor. This is the A, timing of the day, that is the diurnal variation, and the severity of the symptom. Each and every symptom may not have all the characteristics, but the characteristics which fit with the symptom, we can ask. And very interestingly, many diagnoses actually hidden here if we know how to ask and how to get the information. So our symptom is already that weight loss. So you know that the weight loss, what will be the character of weight loss? If you say, what is the place of the weight loss? You don't have any answer. So asking the place is not important. Important is their onset, progression, duration. Character weight loss is not important. Rather, severity is important, that how severely is losing weight, and the speed, that is the progression, and timing of the day. Suppose weight is not being changed within 24 hours. So the diurnal variation is not much important here. So 4 or 5 only can fit about the weight loss here. But if it is the pain anywhere, each and every point is fit here. In addition, there will be one extra important thing what we couldn't fit in these OPD CATs. This is radiation. So especially for the pain, radiation is very important here. So we can add an R within these two words, OPD, R, CATs. It is only for the pain. Others, all the symptoms can be explained by OPD CATs. This is our understanding. So it may be helpful for you also. Then weight loss may be a symptom of which system? This is the question. Suppose cough may be a symptom of respiratory system, cardiology also as well. So these are most important two symptoms. But the weight loss, it may be a general symptom. It may be some symptom, rather to say some endocrine disease. But in broader sense, it can be symptom of each system. To proceed further history taking, ask other symptoms of relevant system. If we think that it could be a general symptom, so we have to go for the general health queries. I will show you a little later what are the general health queries in our history format. If you think that it may be the endocrine problem, yes, we have to think that endocrine problem, diabetes, thyroid disorder can cause weight change, weight gain, or weight loss, whatever. So we go to the endocrine system to ask about the symptoms others of that system. Okay, then we will go for the past history. You know, most of you know how to take the past history, but intentionally we added here in the format the investigations history, that investigation done You have seen already one informations in the Royal College instruction. There are some investigation data. So these also part of the history and the treatment history, hospitalization, blood transfusion, preferably in the PACES exam. These informations are very, very important. Drug history, I will detail a little later. Drug history, including allergy, immunization, family history, social history. Here, it includes very, very personal history. So don't make a extra headline of the personal history, because the person and the surrounding all together make a society. So personal life, diet, smoking, alcohol, very, very private life, and others also. The last one is the impact of the symptom in life. It is not part of the social history, but I just added here to finish the word impact of symptoms in the daily life or professional life. This is very important. I will show you the Royal College checklist. You will find there this word. The last part, it is actually not studied or taught in the undergraduate study usually in the MBBS courses. This is the idea, concern, expectation. But in the Royal College exam, this is very, very must, especially the concern. I have added this thing in actually from the Royal College of General Practitioners concept. I find that it would be very, very important to ask about the idea. Idea means what the patient is thinking about, the reason of the problem, and concern, you know that why patient is worried for, and expectation, what patient wants to get something from you. It may be that patient is not here to seek your treatment or investigation. Patient is here to take a medical report. It may be the expectation, but you are thinking that I will investigate the case and give the treatment. It may not be in the real life also. For that, idea, concern, expectation is very, very important. Lastly, other systemic inquiry, still you couldn't identify the diagnosis, definitely you have to go for the other second line systems, what you didn't ask about before. So this systemic inquiry not only for the diagnosis purpose, this systemic inquiry can give you the comorbidity. This systemic inquiry can give you the etiology of the disease also. So for that, we have to know each system symptoms rather in our mind to ask about. And our practice will be to finish everything in the design time in the examination. Lastly, summarizing, you know, the salient feature in the history. After summarizing, we like to ask two questions to the patient. Do you like to ask anything more? Do you like to add anything more? It will be very intelligent questions at the last point, because you might forget something very important. The surrogate can tell you if surrogate or patient is happy to you. So in course of practice, we will learn a lot about these skills. Today only just starting the basic approach of the history. So again, showing to you, you come to know that the presenting complaint are 3, but the symptom only the weight loss. And the disease are diabetes, recently diagnosed, and some liver function test. So if it is so, now I am inviting any of you that you will ask me about the weight loss, minimum OPD cats. Who will be ready with me now, please? I think it will be your chance to practice. Don't feel shy. Anyone, please? Can you raise your hand? It will actually encourage me also that you are listening and understanding my talk. Okay, Dr. Sharar again. Welcome, doctor. Please. In the OPD cats, you see R, I put here for the pain, other than OPD cats.
Okay.
But the weight loss, I think you cannot complete the OPD cats altogether. There are 7 points.
Exactly.
So whatever the point,
yeah, well,
you will ask me, I am requesting all other colleagues, you will formulate your diagnosis by yourself in your paper, because we will try to reach a diagnosis after the history taking as much as we can in short time. So doctor, you can ask me, you finish your introduction, how can I help you? So you can start with how can I help you? Then I will continue, please.
Okay, now how can I help you, Mrs. Drake?
Yes, doctor, the last, from last 2 weeks, I am suffering a lot. I am losing my weight around 1 month actually, but I attended the GP for the last 2 weeks. My GP given me some tablet for my sugar, because he got my high sugar on that time. But in the last day, yesterday when I attended him, that he told me that my sugar is high, it is not under control. And He also told me that I have some liver problem as well. But doctor, I'm much worried about my weight. Suddenly I'm losing my weight in the last 2, 3 weeks. So doctor, please help me and do something that what is going on with me. Can you identify, doctor, and do some test for me, doctor?
Okay. Now, how did you understand that you were losing weight? Did you measure it?
Yeah, doctor, I have measured that I have lost around 5 kg in the last 2 to 3 weeks, doctor.
Okay. Did you lose any weight before that, or did you feel like you were losing
No,
weight
no,
anytime
doctor.
before the last
In the
three
first
weeks?
time I observed as such, doctor.
Okay. Do you have any other problems such as increasing thirst or feeling weak or even feeling hungry?
Sorry, Dr. Sharar, we don't like to discuss up to there. Up to these only OPD kits. We will do
Okay.
some other part. The design is as such. So
Okay, sir. No,
thank you,
so
Dr.
I
Sharar.
was thinking that we are going to. Okay. Okay.
You can go there also, but here, how do you understand what you are thinking that in the last two you got the duration, progression you didn't
Yeah.
ask that, especially that is it continuously you are losing. You try to that identify that did you lose the weight before or not. So progression may be there. Duration you got. Onset,
Okay.
actually we can set another symptom also, very typical pain. It could be easier even then. Onset, how it started easily. Suppose a pain, how it started. But here, weight loss, how it started. Usually weight loss has started a regular phenomenon. It's a gradually, not that suddenly one day I am losing my weight. For that, this question may not be relevant here. But onset also important. Character not important. Aggravating relieving factor not important. Timing also not important. Severity, so severity means suppose that patient lost 5 kg in the 2 weeks, so it's a very significant weight loss. You know the term significant weight loss. In the 6 month time, 3 month time, when the weight loss is such and such, then we label it significant weight loss. So in the last 2 weeks, patient lost around 5 kg. So this is significant weight loss. This is the severity of the weight loss. So not much actually point here to ask about. So definitely Dr. Sharar will go to the next point.
Okay.
He,
I have one question.
please, please.
How do I get to know the progression of weight loss?
Oh, this is actually not much relevant as the gradually patient losing the weight. Suppose if you ask that, you asked already, are you measuring your weight? Patient is measuring, suppose
Exactly.
3 days, 1 week after, it can give an idea. And another way,
Okay.
it may not be a problem in the exam that they will be educated one. In our real practice, the laymen or less educated people cannot tell losing weight or not and the severity. And in that case, we use our strategy, our culture and other that, do you think that your trouser becoming looser day by day?
Loose or
That may not.
clothings are
Yes,
becoming looser. Yeah.
is very
Okay.
indirect way, may not
Thank
be
you.
important in the PACES exam because there are many other issues to be tested for you. Not that are you able to ask about the weight loss or not. Just about the weighing machine, are you using or not? That's enough. Okay. Any more question?
Okay. Thank you, sir.
Okay. If anybody also, you can raise your hand if you try to add. Otherwise, Sharar is there. Is very eagerly waiting to talk about. Okay, Dr. Shah, get ready with you. I think you are thinking something that acute weight loss in the last 2 weeks, having abnormal liver function, and patient newly developed diabetes for the last 2 weeks, and patient is on diabetes treatment. I think clear, Dr. Shara. Sorry, can you raise your hand, Shara? Again, you are muted. Can you raise your hand? Then I can give you the mic. Sorry, Dr. Shara, you don't unmute by mute by yourself. Okay.
Okay.
Anybody,
Okay.
please get ready. Anybody can get the chance. There are some other parts also for practice. Anyway, Dr. Sharar, in the weight loss, what other system question we have to ask? First, we have to go for the general health query. I will show you the list how the general health queries are. The DOAMS set. It is not from the book as it is. We actually copied here. For to be realistic more, we gathered the information and divided. We made many sectors of the history sheet. So general health query, very, very important. Weight loss. Health query means the fever, anorexia, weakness, sleep pattern, and the lastly, the mood also. Issue of the mind. And other system, Dr. Sharar, can you tell which system more important? Already you know about the endocrinology. Any other symptom? Any other system? Can you tell?
Well, the alimentary system, maybe
Alimentary system, because weight
she
usually
has
related with the food. So we will ask
food,
definitely
yeah.
from alimentary system. Any other system? So if we tell that the highlighted system are those, so I think Dr. Sharar also right, and I tried also to make up these. Can you see here, Dr. Sharar?
Yes.
And your thinking and our thinking almost same. So I like to congratulate you. Very, very good. You are
Okay.
our attention really. So these are three major headline area we have to ask initially, initial part of the history taking minimum. If we don't get any diagnosis there, then we will go for the last part, systemic inquiry, respirology, nephrology, and other. For not only the diagnostic, rather etiology and other clue also. Etiology may be known from the past medical history or hospitalization, anywhere else. This is the glamour of the history taking. Anyway, if need the very, very personal history, sexual history also important to the weight loss. If it is a young lady in the reproductive age, maybe that she is suffering from chronic illness from sexually transmitted disease, HIV, it may be a reason of the weight loss. It could be. So many things happen in the patient. So now come to the cardinal symptoms. I will tell you how to, what information actually, what the symptoms in each and every system. First one, it is not the symptom, it is a general symptom. That means in any disease it may happen. But we added something intentionally. You will understand. Fever, you understand, Dr. Sharan? Malaise, appetite, that
Yes,
means
sir. Yeah.
anorexia, polyphagia. Polyphagia, though, may be a features of the endocrinology. You can ask here as opposite of the anorexia. Weight change, already this is your presenting complaint. Sleep pattern, generalized weakness, and the fatigue. So why generalized weakness? Focal weakness is a part of the nervous system query. Blood loss, that means the hematology. So general health query includes especially some information regarding hematology also. So if we can ask something from here, we can exclude or remove some other systemic query, because systemic query may be a longer one. It can take more time also. Lumps and bumps, again, you understand, it could be the lymph node in the neck. So again, in the hematology, well-being, overall asking of the patient, especially needed for the follow-up of the patient. How are you feeling today, as before or worse than before? Mood is the state of the mind, mood how to ask, and the menstrual obstetric history. So it will be a bigger practice session really. For that, no need to discuss many things. Impact of symptom in life. You can ask earlier, you can ask the later part of the history. But some intelligent candidate is advising that, oh, you ask this impact of the symptom very early because you may forget. If you think that you are very forgetful doctor, so you can ask this early. But early asking is not good hearing that after finishing the talk, last question will be how it is hampering your daily life. It could be better one. This is my suggestion. If the patient is female, menstrual history, obstetric history, especially the pregnancy loss. You know that as the case of Apla syndrome and phospholipid antibody syndrome, pregnancy loss is very important. So special highlights are here. So all are the things how to ask. Again, it is a matter of further practice. These are the things. Even then, Dr. Sharar, are you crazy? Sorry, not crazy. Very eager to ask this thing to me.
No, it's okay.
No. If please
What?
don't. You can ask very quickly. Just I will clarify or try my best to correct you if you do any mistake there. Don't worry.
Well, I was thinking that maybe if the patient has any kind of pallor or weakness, there is no weakness
Patient may have
present in this
no
general.
problem. It is just computer like question. This sheet.
Okay.
Yes, no, yes, no. Do you have fever? Do you this thing? In real life also as such, because patient is not presenting with fever to you. So only having or not, because it can guide you for the diagnosis. Suppose weight loss, if patient is febrile, patient might have infectious disease or a neoplastic disease, right?
Okay.
So
All right.
quickly, you can ask.
No, I don't have any questions.
From the fever, now the practice is that how to ask the question, how to talk to the patient only. You just ask.
Oh, okay. I am going to ask you now. Okay,
Yeah,
as
yeah.
a patient. Okay.
Please.
Okay. Do you have any fever
No, no,
in the
doctor.
past couple of days? Okay. Any sort of weakness or sleep disturbance?
Yes, I like to pause you now here. And my beloved colleagues, listen to me and to Dr. Sharar. Doctor asked that, do you have last sleep and other, Dr. Sharar?
Sleep or a weakness?
Weakness. This is called double barrel question. Possibly, if again,
Okay.
I like to refer to you all that you couldn't attend my previous talk, I explained there what is double barrel question. So here, if you ask me that, do you have sleep problem or weakness? If I tell you that yes, doctor, what you understand? Am I having a sleep problem or the weakness? It may be confusing. So question should be one by one,
Okay.
not double or multi-barrel question. So ask one by one. For that is a practice session only. I requested you ask me one by one again.
Okay. Do you have any loss of appetite?
No, doctor.
Do you have any change in appetite?
Oh, sorry. I like to correlate the symptom of the weight loss, the liver function test. Can you ask me again?
Okay.
Appetite.
Okay.
Appetite better. They understand the appetite in the layman term also. But are you or did you lose your desire of food? You can tell it that way. Desire of food.
Okay. Okay. Did you lose your desire of food?
Yes, doctor. Last 2 3 weeks, I cannot take much food because I have some problem in my tummy also. Do you
Okay.
understand, Sharat?
Are you
Tummy means,
sleeping well?
sorry,
Yeah,
Sharat,
exactly. Your
tummy is
abdomen.
abdomen. Many of you know tummy.
Yeah.
But thing is that
Okay.
you ask one question, patient is giving you another answer. So this is that patient, how patient is giving information to a doctor. But we sometimes skip the information. This is our mistake. Patient is giving all information most of the time. So you got that patient having a tummy problem. You are also thinking that patient may have some alimentary system problem. So you got some clue that patient might have problem in the abdomen. Might have.
Okay.
Okay, proceed on.
So, are you sleeping well?
Nowadays, doctor, sleeping is hard because I have tummy problem and thinking also a less sleep, a little disturbed, doctor, but not very significantly.
Okay. Are you having any sort of blood loss from
No, doctor.
anywhere?
No, no.
Okay. Do you feel any kind of lumps anywhere in your body?
Lumps and bumps anywhere in the body. Yes, I don't have, doctor.
Okay. What about your mood? How are you how is your mood these days?
Okay. Yes, doctor, now I'm feeling low.
Okay.
Low
Are
means
you
is a symptom of depression, right? Symptom of depression.
okay?
And just I forgot, sorry, I interrupt you because you ask in one information in double sentence. So you are using your
Okay.
two sentence. No need to use two sentence, only one sentence. What about your mood? But
Okay.
indirectly, in a layman term, to ask about the mood is that how do you feel? How do you
Okay. How
feel?
are you feeling?
Yes, it's a big areas also the layman term. Today, I think not possible all the layman term. In course of discussion, I will give you some layman term. In future also, you will come to know in a design practice session. So how do you feel only? Mood. I feel
Okay.
low. Next question.
Are you having your menstruation?
Okay. Dr. Sharad, the word will be period.
The
What
age
about your
is
period?
okay.
Age also higher. You
Okay.
understand
Your
that
periods. Yeah. Okay.
patient may be
Okay.
in the
Yeah.
menopausal age. Even then, what about your period?
Periods. Okay.
Ask again, please.
So
Practice.
what about your periods?
Doctor is stopped in the last 5 years, doctor.
5 years. Okay.
So
Did you
what
have
Dr.
any?
Shara, you know that you already got another diagnosis of the patient now. What this is
Okay.
5 years post-menopausal lady. This is also your diagnostic
Postmenopausal.
list.
Okay.
It will be included in your it is called actually
Summary.
problem list. Problem list. Diagnosis will be weight
Okay.
loss, the etiology may be there, but the problem list, it is called problem list. In the final, you have to make a problem list of the patient. Proceed, please, Dr. Shara. Anything you like to ask?
So, have these symptoms been affecting your daily life?
Yeah, doctor. Nowadays, you see that I am a social worker in my area. Every day, I have to go to the club there to chat with some people. Nowadays, I cannot do, doctor. So this is the symptom.
Okay.
So the
Thank you
glamour of
very
the
much.
consultation here, doctor, is to say, I am sorry for that.
Okay.
Again, I don't like to expand my talk here. Dr. Sharar, can you tell? I am sorry for that.
Okay, I'm sorry to hear that.
Yeah, this is called the decoration of the consultation. Anyway, many decoration will be in future. Thank you, Dr. Sharar. Up to this general health query, now we will come to the other systemic inquiry. That means not inquiry, to ask about the relevant system. So this is the cardiovascular symptom. You can see in the book, almost same. Joe, we have done a little modification. If you can request us, we can provide you the total list on request. It is for you. How we design it. This is the respiratory from nose up to the alveoli, whether to cover runny nose and there. So now I think the elementary system is important. Please, again, asking, requesting also other colleagues who will be doctor to ask the question to the patient if you try to practice. Sharar is always ready, no problem. Adnan now, Dr. Adnan. Dr. Adnan.
Yes, sir.
I think Sharar, you can take a little rest, then Dr. Adnan can ask. For Dr. Adnan is
Okay.
raising the hand. So from here, elementary, you already came to know that patient having tummy problem on the upper tummy,
Yes, sir.
right? So
Yes, sir.
it means that you have to complete the whole symptom almost. This is the formula, tricks and tips for you that if you find any symptom of any system, you have to ask all the systems. You understand or not, it is not a
Yes.
problem. This is the what I say, magic of the history taking shift like this. You may not understand here what is the importance of asking something else, but when you summarize the symptom later, then you will understand the importance of this positive response from the patient. Please, Dr. Adnan.
Do you have any mouth ulcer?
Beloved colleagues, again for your information, it is called sore mouth, not mouth ulcer. Sore, S-O-R-E, sore mouth is the layman term for the patient. Can you ask again, Dr. Adnan?
Do you have any sore mouth?
No, doctor.
Do you feel any difficulty in your swallowing?
No, doctor.
Do you feel any nausea or vomiting during this period?
I think Dr. Sharar can comment here asking nausea, vomiting. Sharar, can you keep your hand raising? You don't be muted. Interaction is important. Can you raise your hand, Dr. Sharar? I have to control from here for that. Keep open your mic, Sharar.
Okay, sir.
Okay, Dr.
No,
Sharar.
I'm keeping it muted because there is other sounds coming
No
from
problem. Only
the
two, not
background.
enough.
So.
Because I need some input
Okay.
from your participation also. If anybody can comment here, we will be actually open to accept that. So here, Dr. Adnan asked me, do you have nausea and vomiting? Dr. Sharar, do you agree with this question?
No, it's becoming double-barreled again.
Yes, yes. Do you understand, Dr. Adnan? Is it double barreling?
Yes, sir.
So you have done a little mistake here. Again, layman term is not the nausea. Nausea means, do you feel sick? I think all the colleagues can write down in your paper the layman term. I will try to tell you almost some layman term today. Do you feel sick? And the vomiting, do you throw up? Adnan, can you remember?
Yes, sir.
Do you feel sick? Do you throw up? Quickly. You can ask Adnan.
Do you feel sick?
Yes, doctor, I feel sick in the last 2 weeks as well.
Do you throw up?
Yeah, doctor, in the last 2 weeks, I have thrown up 2-3 times.
When you throw up, is some blood came with it?
I didn't see, doctor.
Do you feel any kinds of heartburn?
Heartburn is a layman term, you are right. But it is actually retrosternal pain. So, yeah, I don't have heartburn, doctor.
Do you have any abnormality in your digestion?
Rather to say, do you have any problem after taking food? Any problem in your tummy?
Do you have any problem within your tummy?
After food? After food, dyspepsia or indigestion, rather meaning food related issue. Indigestion means you are taking the food then having trouble in the tummy. This is the indigestion, dyspepsia, like that. Yes, doctor, after having my food, I feel discomfort in my upper tummy, some burning there in my upper tummy.
Have you feel any tummy pain?
No other area pain, doctor. I am feeling pain in my upper tummy.
Any kinds of bloating sensation in your tummy?
Actually, word will be fullness, feeling of fullness. Better to avoid the bloating. Do you feel any abnormal fullness in your tummy?
Do you feel any abnormal fullness of your tummy?
No, doctor, not as such.
After that, do you feel any
No, how to ask about the bowel? What about your bowel? Like open question. What about your bowel?
what about your bowel?
There is no problem much, doctor, but nowadays I find that I am having little loose stool and sometimes difficult to flush, doctor, in the last 1 or 2 weeks.
Do you see any what is the color of your stool?
Little oily, doctor, whitish. Okay, Dr. Adnan, thank you very much. So, Dr. Sharar, can you summarize here what information actually we got from these elementary query? What is happening wrong? Could be.
So the patient has some malabsorptive symptoms.
Yes, you are right.
The patient has heartburn and feeling of fullness, bloating, as well as abdominal pain in the epigastric region.
Yes, bloating actually
as
not,
well as,
not there. Patient didn't tell about bloating, rather told about upper GI symptom, right? Upper GI symptom.
Yeah, exactly.
So now you can think that this is maybe in the near about the liver, maybe in the stomach, maybe in the gallbladder, maybe in the pancreas. Okay. So only systemic query, how can we summarize from only elementary symptom? If any patient having the upper tummy problem with steatorrhea, could it be peptic ulcer disease only? Or it could be pancreatic disease? Again, Dr. Adnan become muted. Dr. Sharar, can you answer? Upper tummy problem with steatorrhea.
It may be pancreatic.
It could be pancreatic.
It may be pancreatic, yeah, exactly.
It may be gallbladder disease, is not it?
Yeah.
It may be gallbladder disease.
It could be gallbladder.
It
could be gallbladder.
Yes. But if it is gallbladder disease or in the obstruction in the biliary tree, patient might be jaundiced. So bilirubin is a little high. It could be there. Clinically, you will examine the patient later. Maybe there. So it less likely of peptic ulcer disease because patient develop steatorrhea. So this is now in the pancreas or somewhere else. Maybe. Okay. That's right. So from there we got these, and the urinary symptom, it could be associated symptom. And now come to other neurologic also. Really big list: psychiatric, musculoskeletal, endocrine. What didn't you ask before in the general query? You can complete here. Dr. Sharar, I think you can complete endocrine.
Okay. Are you feeling hot or cold?
And now you are the same problem. You commented to Dr. Adnan, and we are alike. We comment somebody else.
Okay.
We are doing the same. Double barreling. Correct it, please.
Okay. What do you think of the temperature outside?
No, in that not the
so
way.
in this case, we have to give a choice. If you are giving a choice that whether it's hot or cold,
anyway,
I don't think the patient will reply with yes or no.
I am giving the tricks to you, Dr. Sharar, for the practice purpose. Okay. How to ask? We can ask that: are you feeling excessive? Not the hot actually. Better to use the word warm.
Okay, warmth.
Previously,
Okay.
we are using the hot, but nowadays there is a little criticism about the using word hot. Rather to ask about, are you feeling more warm than before, or unusual warmth than before? Are you feeling unusual cold than before? It may be the question. It may be one of the type of questioning. But
Yeah,
what
Dr. Hagi here suggested one thing. Can we use that do you prefer hot weather or the cold weather? Is that
maybe
acceptable?
many ways are there. Many ways are there to ask about. The
Okay.
thing is that patient having a hot intolerance or cold intolerance. Suppose in
Yeah.
some cultures, when patient doesn't understand what I mean for these excessive or unusual other thing, rather how can we ask that? Are you using more blanket in this summer season? Right? Summer season you are using more
Okay.
blanket. In the winter season, are you using very thin cloth that you cannot wear a thick cloth? It depends upon the patient level of understanding. Many ways are there,
Okay.
but question is that it should not be a double barrel one, not be double barrel one. Again, you have to use your time also, utilize your time also. A patient losing the weight, are we thinking that patient is of primary hypothyroidism? No. Clear, Shara?
Okay.
So why should we ask about the
Yeah, exactly.
cold intolerance? Rather, we can ask about
Okay,
the
okay.
warm intolerance or hot intolerance. It could be
Warm
thyrotoxic.
intolerance, yeah.
Weight loss, though this is steatorrhea, it could be hyperdefecation, excessive bowel movement. It could be thyrotoxicosis. So we will not ask
Thyrotoxicosis,
about
yeah.
the cold intolerance here. Rather, we will ask about the hot
Okay.
intolerance here. So this is the tricks, how to proceed the history. Then quickly finish, Sarah, change sweating and other.
Okay. Are you sweating a lot?
Is there any change of sweating?
Is there any change of sweating?
It isn't better. Some people usually sweating much more. It is a habit without any explanation also, For that, better to ask,
Oh,
is there
okay.
any change of your sweating recently?
Change in sweating. Okay.
Yes. It may
So
be
is there
usual.
any change in sweating?
No, doctor, as before.
Are you feeling thirsty all the time?
Are you feeling thirsty all the time? Yes, doctor, I feel thirst to take my water. So question will be a little different. Are you feeling more thirsty than before?
More thirsty than before. Okay.
Could be.
So are you feeling more thirsty than before?
No, doctor. Uh, No, doctor. So thing could be difficult here. No, doctor means you think that patient is diabetes, but patient is not feeling thirsty. Maybe that patient developing some other illness in addition that he may not be thirsty. Sorry, he may not be taking much food. Thirst may be there. The blood sugar will be very, very high. So patient having 12 or 11, it may not make the patient thirsty also. So there may be plus minus
Thirsty, yeah.
informations. May not be plus minus information
Okay.
from here. So just to tell you that how to ask the question, not very serious about the information's explanation. So that's all. And already you asked about the menstrual obstetric and other history from the lady. Now come to an observation of the systemic inquiry and the evaluation of the symptom. This is a formula to give the importance of hard symptom and the soft symptom. May I request all of you to make a snapshot? It will save my time. Then if you go through, it will be helpful. That's enough. I'm jumping there because practice session can take more time. So you know about the vomiting patient. You know about patient having steatorrhea, but actually you could not finish the required information of the vomiting and the required information of steatorrhea. So it can be helpful. Suppose you may think like a mnemonic COCA, FF, or COCA, whatever you say. So 6 informations from the stool is very important, especially content, order, color, amount, frequency, and the flashability. So you, my beloved guys, colleagues, you will practice by yourself how to ask this thing. In another session, if possible, I will interact with you. So the 6 points to be asked, especially for the stool, but the vomiting, we don't need to ask about the flashability, but other 5 things are important from this vomiting. So you have to finish it, vomiting. If other colleagues are willing, then I can give the chance. So up to these, If you have any query in your mind, you can raise your hand. What we discussed. Now coming a little few minutes more. I hope that you will be until the end. So I'm not seeing any raising hand. So again, this is the format. So there are some remaining part, past history and drug history. So I think no need to practice further. If new colleague wants, then I can give the chance. Otherwise, I will proceed. Social history, we discussed a little. Family history. Family means father, mother, brother, sister, and the son, daughter, if they are married. These are three levels of family history. And idea, concern, expectation, I already told before. Systemic inquiry, and the how do you like to add anything more, and they ask anything more. So sorry, I couldn't attend your chat box. Dr. Hagi told that, do you feel sick? Oh, like, yes, we talked before. Do you feel sick? Yes. Or do you throw up? This is the thing. Okay. Could you ask it, patient, if this weight loss was intentional weight loss? Yes. Someone asked that intentional weight loss or not. It's very important. But from the way of talking, do you understand that patient losing weight intentionally? No. Patient is telling doctor that I am losing my weight and I cannot take my food and I have some blood sugar high. Actually, indirectly, it is giving an information that it is not intentional weight loss. Intentional weight loss could be there only if you don't have any other symptom, almost only losing the weight for some reason hidden, but the reasons are very obvious here. So seems to be that it is not intentional. But again, you are very open, free to ask the question to the patient that the is it intentional or not? May not be bad. I agree with you. But if we understand the flavor of the question in the session, better we cannot ask, no problem. Okay, doctor, thank you to ask the question. I'm sorry I couldn't give attention in the writing. I like that you will raise your hand, talk to me directly. I feel better in the interaction. So this is the list of the drug history. You can again go through, you can see the book, make a snapshot. But very important thing in my sense, I like to highlight here. The other medications not prescribed, over the counter or herbal medicine or the vitamin, patient may not tell you. If you ask that what medicine are you taking, patient may think, usually thinks that you are asking about the prescribed medicine, but these are not prescribed medicine. Even oral contraceptive pill not seems to be a drug to the patient sometimes. So better if we think that asking about the OCP is important, we must about the OCP, that are you taking birth controlling pill or not. Our patient is postmenopausal, may not be important, but we can ask about, are you taking any hormone replacement therapy, the hormone pill in the aged stage of your life, maybe another way, though not much important here. And for the drug history, sometime we have to check the GP prescription. May check, you have to check the medicine box. I had in my examination, I can remember, I checked the medicine box because patient cannot tell the name of the drugs, what she is taking. So drug history is very, very important, and this list is very, very important. What is not written in the book, I face in my life, in my practice. Just I am showing that is a grandfather, is a grandson. So I asked the grandfather that what medicine you are taking. Grandfather forgot to tell me. Then grandfather requesting the grandson that please can you call to your grandmother what medicine I am taking. So this is the video you see. The young boy is asking. I'm not extending the video. Regarding diabetes and other, it's a very native language. Oramet and the Neurobase, there's a vitamin and the metformin drug. That's enough. So this may be the way also to get the drug history. So I'm just adding my life experience with how to take the drug history. Anyway, so it may be a very extensive information drug, including drug allergy also. Don't forget. So this is a sexual history. If you think that is a STD related disease, it's very, very, very private history. All the informations, each one needs 1 minute or half minute. So I like to hear from you again. Introduction is very important. Again, may I ask Dr. Adnan, please, can you start how to take the private history? Only the first sentence. You can tell on your own words, no problem. Dr. Adnan? Hello.
Hello, sir.
Yes, please. Just
Past,
this is
past,
called again privacy maintaining and seeking second permission. Will you ask or not?
sir, keep past history, sir.
No, no, no. This is sexual history.
Oh, sexual history. Okay, sir.
Because this is private history, it needs special attention. In the concept of the consultation, it is called meta communication, or in simple word, what I say, signposting, that what you are going to ask now. Because it's a very private history, patient may be embarrassed. For that, you have to tell that may I ask or not. So,
I
Dr.
would, I would like to ask private question, if you don't mind.
But you have to explain the reason of asking private question. Better not to use the private question. Be very simple and open. Now I like to ask some questions. Private also may embarrass a patient.
I would like to ask you some questions.
Which may be embarrassing.
I would like to ask you some questions which may be embarrassing.
But can you not see the screen, Dr. Adnan?
Okay, oh, I don't know.
Why not? It's already visible in the slide. Sorry, Adnan. Is there a problem?
Network, some difficulties, right?
Okay, let me say. That I like to ask some questions which may be embarrassing to you, Mrs. Drake, but I think that is very important for detection of a disease and to give a very good treatment, Mrs. Drake. Is it okay? Clear now, Dr.
Yes,
Adnan?
sir. Yes, sir.
Is it okay? It's just courtesy, just to make the patient free and actually generous to talk about. In the meantime, you talk a lot with the patient. Patient definitely having a good developed a good rapport to you. Even then, for the private history, personal history, or psychological or internal relationship history, we have to approach in that manner. Clear, Dr. Sharar? I'm
Yes, sir.
asking to
Yes,
all
sir.
of my participants also. Anybody can react or comment. If we do any mistake, you can correct us. So after this finishing the history taking all together, social history and others. So now come to the management plan. It could include these 1, 2, 3, 4, 5, 6, 7 points. So there is some special code given. It is from, again, I like to tell you, the Royal College of General Practitioners. Though I modified some words here for our better understanding in the PACES. So these are the things we have to follow in the management plan, including hospitalization referral. In the management part, we must think that should we admit the patient, should we refer the case, and if it is outpatient, should we actually give a very near follow-up with the later follow-up, or patient may again attend to the GP, not to me. It should be decided from the history. So the history we have taken can be a case of pancreatic cancer. I'm just telling you the summary. Last 2 weeks, patient developed upper tummy problem, weight loss, vomiting, and some obstructive hepatobiliary feature in the investigations. So it could be a case of pancreatic malignancy. So how to give the bad news, how to break the bad news. This is also part of the communication skill. But here, definitely we must hospitalize the patient. Okay. But if it is outpatient department, maybe peptic ulcer disease, so there could be a matter of safety netting. Who can tell about safety netting? Again, Dr. Sharar or Adnan? Anybody else also? Safety netting, how to tell? Suppose I like to give an appointment time 2 weeks after to come back with the reports. What could be the safety netting? Dr. Adnan, can you tell? Sharar
Give
also.
your contact number. Maybe you can give your contact number, so if in case
How
of
to tell?
emergency they can call.
Yes, I just say, sir, this way.
Okay, Adnan, please, can you tell?
Okay.
Is it okay? I do not know, I just make myself it is. I'm sorry again for hard news today. I will give you some leaflets, brochures, and website to know more about the disease. I will give you my contact number as well to call me if you have any worries and queries anytime.
It may be a good approach also. You're choosing the words very nice, I understand, but the safety netting is not including each and everything what you have told. The giving the brochure, website and other, it is actually part of the explanation of the disease or the treatment and other. Safety netting means If you give the follow-up after 2 weeks, in between these 2 weeks, patient might have some dangerous outcome. Something happened wrong. In that case, what patient should do? Maybe your phone number, but again to tell you, giving the personal phone number is not professional. Remember, it is not
Okay.
professional that I will give my personal phone number to the patient, because we are working in a team, in a professional team. Why should I take the issue personal one? Is not it? It's a teamwork. I am here, patient will go some other service area, patient is to be under investigations, referral, others. So how many personal phone numbers should be given to the patient? But you are the main point of service as a duty doctor or the outpatient department doctor. So you will give office number. I'm giving my office number here. If you have any problem within these 2 weeks, please don't hesitate to call us. We will be ready to serve you. Maybe in that manner. Okay, Shadar and Adnan?
Yes, sir.
Good.
Yes. Yes.
It could be the reason. Anyway, there are some other things I don't like to add much more. Don't be judgmental just to tell something that the etiology may be there. Suppose patient having a smoker, okay, alcoholic. Suppose in this patient, alcoholic. Yeah, she was much very what is addicted to the alcohol. But we should not tell that in a judgmental manner. You have taken much alcohol for that you are suffering. It is called judgmental comment. Like lung carcinoma, you took or you smoke a lot in your life, so you are suffering from lung cancer. This could be a judgmental comment. It is not approved. It is not actually a professional one. In real sense also, you know that smoking is not etiology of the cancer. So I am not true also 100% case. But thing is that we will not hurt the patient in the mind that he or she has done something wrong in the previous life, for that he or she is suffering now. It is called judgmental. We just tell some correlation that you were smoking a lot, maybe it may cause something like that, not in a very judgmental manner, but we have to tell the truth. So anyway, I am not being much sticky in this slide, but in the next slide, you are thinking that these are the questions repeating to you after talking to the patient. Examiner will ask you. Before that, sorry, it's another slide. What the patient can ask you, not the examiner. There is some traditional asking of the patient's mind. Please have a snapshot. That's enough. We have to concise the time today. So this question you have to be ready for each and every, especially the female patient. They will ask about their married life, conjugal life, about the baby also in the future. What will happen? What will happen? This is the questions. That instruction given to you. Give the answer of the question if they raise anything in the your task. You can remember in the instruction. This is the question, usual question. But patient may ask many other question also. So this is the examiner question list. Respond to the examiner. What is your diagnosis and other we described before. Anyway, I don't know, I'm taking much more time. Please don't lose your patience. I'm trying my best to make you understand. So the part of the history, now maybe we can conclude within few minutes. Before entering the examination hall or the room, you will be given a paper. You can write with your pen in that manner. This is our proposed plan. You may make a better one also. We divide the paper in the 4 parts. Initial one is the backbone, the headlines of the history taking. In the right side, you will write the instructions given. Suppose in our patient presenting complaint, you already told is weight loss, abnormal liver test. And the abnormal liver test, your opinion also will write here that it is obstructive pattern. In the right side, you can write obstructive pattern. You may not remember the actual level of the alkaline phosphatase, but you can write that LFT obstructive in shorthand. Then come to the OPD cares of the symptom, weight loss, and other relevant system, including general health query. Is very important, general health query, because weight loss is a very sinister information. And then the past history, the 3 headlines, drug history, given 4 or 5 headlines also you can add here. If you know, because you know that patient is asthmatic, inhaler she's taking bendroflumethiazide also, right? The family history also, their father, mother, social history, personal life. Last one, impact on social life. Red mark must not be missed. Systemic inquiry, ICE must not be missed. Then Examination means you will not go for the examination, but examination plan you have to be in your mind, because the examiner may ask you what examination you like to do, what investigation you like to do. For that, apparently within 5 minute waiting time, you can have some planning in the paper. The remaining informations, all the information definitely will not be there. The remaining information will ask from the patient. Finally, you will make a problem list. It is not only diagnosis. Patient having many problems. Suppose patient having diabetes, patient having weight loss issue, patient having the liver function test. These are the problem, biologic problem. Patient mood is low, so it is a psychological problem. Patient is poor, she or he cannot afford much money for the treatment. Those who are not covered by the government, it is a social effort. Patient is alone in the home, in the social history. No carer is there. Patient is divorced. Patient is actually homeless. Many problems. All the problems should be listed here according to the importance. Sometime examiner asks, what are the problem list of your patient? So how you are going to solve the problems? If possible, make this. Initially, it will be blank after talking one by one, one by one. In this case, actually, patient having the problem of treatment, because the GP thought that it could be type 2 diabetes and he advised metformin. But you know that side effect of the metformin is upper GI symptom, sometimes lower GI symptom. Moreover, if it is due to insulin deficiency in the pancreatitis or the pancreatic disease, metformin cannot help. Any oral drug cannot help. So you have to advise the insulin treatment. Suppose if you can understand from beforehand, you can write here also that the diabetes treatment, possible treatment will be insulin, so that you will not forget in your consultation to the patient. For the some clue, you must write in the paper. You will carry the paper inside and keep over the table and maintain the eye-to-eye contact. So that was that case. Now at the last, I am just showing an other example of patient complaining of the back pain. You can make such structure also with some example. History, you will ask OPD cats, symptoms of the back pain, and the relevant system definitely musculoskeletal, including the skin, and then general health query, a lot of things, 8, 9, 10 points. Then past history, drug history, family history, social history, manual worker in other housing. You mean that low back pain patient housing is important. Are they using lift or not, or manually going up a stair on foot? So again, the back pain patient using the drug, patient might have GI problem. So GI tract system also important. Patient may have renal problem by the drug issue. So urinary system also important. In that manner, you can make your symptom wise chart as much as you can. It is better if possible. Otherwise, if you can follow the structure, also helpful. No need to make each and every symptom chart like that. 4, 5 only as a prototype, not hundreds of chart. You cannot remember 100 chart. Make this type of a structure. It is called that the learning how to fish, not learning how to eat the cooked fish. This is a Japanese proverb that learn how to cook fish so that you can eat the fish years together. So one basic structure is important here. So on examination, your plan and investigation also. From the history, you see low back pain, there are some differentials. It could be the investigation plan and the finally a management plan. Before crossing the examiner, because you will be given 1 minute time. In this 1 minute time, you can plan in this manner your examination, investigation plan, and the management plan in very short hand. Now be courageous to answer each and every question of the examiner. Definitely, they will not ask you very ambiguous, very new question. They will ask about the question related with your patient and you talked about. In the 15-minute time, you will be given 14-minute time. So this is only structure. Lastly, how to proceed in the history station. 12 minutes, what you will do. First 12 minutes. How can I help you? Start it very open. Ask one by one symptom and other. From open question to close question. From close question to probing question. So I cannot detail much now. In the later part of today, you may be exhausted. So probing in another session, if possible, in the communication, later we can talk about different probing, how to ask and how to choose the word. Complete history format logically, we already described. Lastly, the last 2 minutes, wrapping consultation with shared management plan, including other thing. What other thing? Investigation planning also. So wrapping here, that suddenly couldn't ask ICE. You know that ICE is very important. Immediately go there because mark is specially distributed there. You didn't ask about the social impact. Your bell is rang that 2 minutes left. 2 minutes left. Oh my God, I couldn't ask ICE. Try to ask the ICE earlier. Immediately finish your ongoing paragraph, then ask about the ICE. Then ask about the social impact. Then think other. So within last 2 minutes, you have to answer the questions of the patient also. Some questions they will ask. After finishing, you will be given 1 minute. So the last 5 minutes, examiner will ask the major headlines are as such. What is your diagnosis, differentials? How will you investigate the case? How will you manage the case? How will you examine the patient may not be a routine question, not always, because this is basically history station. But some examiner may ask you if some examination finding could be very, very important. Rarely they may ask you, but investigation must. How will you investigate this case? This is the last slide. This is the checklist of the examiner. I think I will not detail much. You just have a snapshot if you don't have the satisfactory characteristics of a candidate, unsatisfactory candidate, the performance of a candidate. If you don't understand anything, feel free to discuss in the group. We will try our best to give you the feedback. So these are satisfactory number is 2 for each skill, borderline is 1, and unsatisfactory is 0. There is no negative mark again. So it will be together. There are 5 skills: clinical communication skill, patient concern, and other. So welfare and other. So this is my last talk, and thank you very much.